I'm trying to get myself on video though, and I can't get that right. Hold on a second. Start video. There we go. Sorry, I had to battle to get the video going. Good evening, Brad, and good evening to Tanya and all our participants from ASAIPA. It's very nice to have you joining us and to have Brad as an exceptional speaker. We're really privileged to have him. Brad is a corporate advisor for 22 years in management consulting experience, and he's a multinational advisor and consulting in various aspects from the UK to the European and Middle East and Australia. Brad's focus in the past decades has been over experienced corporate executive building internal resources and sourcing for delivery advisory and consulting services in multinational operating environments. So we're really very privileged to have such an amazing person speaking to all the ASAIPA members this evening. We are from MC Villiers Brokers. We're a strategic partner with ASAIPA, and we are aligning with ASAIPA and Genoa to offer you a preferential medical malpractice cover for the association membership. And we're looking at many opportunities and leveraging many aspects in the business. So I think Brad's discussion tonight is going to be incredibly powerful and extremely valuable to the ASAIPA members. And we hope you enjoy the session. And I know we're very tight on time, so it's a very tight agenda because of all the load shedding, which I'm sure you're all accustomed to. So over to you, Dr. Brad Byra.
Jeanette, thank you. Hi to everyone. So nice to see you all virtually. I say see you all because I know it's a relative thing and we can't actually see each other. It's a little bit like talking into a dark room when we do these presentations, but after 2 years, it's certainly getting more fun. What I am going to do, if you don't mind, is I'm going to switch off my video and end the bandwidth. But what that'll do is, well, I'll see if I can switch off my video. In theory, it sounds like I can, but in practice, I might not be able to. But today's talk is around telehealth and the transformation of practice in medicine. So this is a big month for me. I got my first paycheck for seeing patients in this month in 1995. And so I earned the princely sum of 20 Rand that year and that month. And so that was quite exciting for me. 20 Rand at that time was a lot of money. I could buy at least 3 hamburgers. But a lot has changed since then. And I remember at that stage, I had an IBM computer that had 256 kilobits of RAM, not quite what we've got now. And life was different. The idea of being able to have these kind of conversations was completely sci-fi. It was sci-fi. It was completely unheard of to be able to have communications and do these kind of real life video streaming discussions around anything, not to mention medicine. So at that stage, we had 286 and 386 computers, and equally, not to mention the computers, we also had, and you'll remember this, many of you, desktop Merck manuals, and we had MIMS manuals, and if you wanted to do something, you literally picked it up, opened the book, paged through to what you needed to page through, and that was your idea of research. When I did my first master's, which was in 1993, that was on the effects of spinal manipulation and adjustment on low back pain and radiculopathy. If I needed an answer or I needed a research article, I would handwrite what I needed to do. I would take it through to the library. They would post it to the library where that research was done, who would then post back in 2 to 3 weeks the results of my research. Now I can go on and I can Google it. And one of the medical legal cases we're busy dealing with at the moment, the parents say, well, you know, we Googled actually what we thought was wrong with our son. And here's the proof that we Googled it at this time. And so consequently, we want that kind of outcome. So the world has changed. And that introduction into Google and into patients looking at our data and us looking at their data, and the old joke of my medical degree trumps your Dr. Google is now more along the lines of my medical degree gives context to the information you get off Google. So the world has changed, and I use that as the introduction preemptively to what we're going to talk about today, which is telehealth and the transformation of medicine. So when we look at medicine versus health, and we look at transformative technology, that picture was taken on the Namibia-Angola border, where I worked for one of the Swiss NGOs that provides support to rural clinics. And there was this amazing thing. You had this handheld device, you had a dongle, you could do ultrasound, that could be sent via, at that time it was the LTE technologies that, or 3G, that could go back, and somebody remotely could give a second opinion. And so now when we start talking about the WHO's definition of health as a state of complete physical, mental, and social well-being, not merely the absence of disease and infirmity, we've got to start asking ourselves the question, how do we define a consultation? Is a consultation between two people face-to-face? Is it between a patient face-to-face with a practitioner, with a second practitioner providing remote support? And do we regard virtual consultations as being part of value-based care? And is telehealth person-centric? Is it interoperable? Can we shift goals, resources, and talent and technology between different people, between different places, and still give intimate, socially appropriate care? That's a big discussion. So what we're going to do today is talk about that. And I'm also going to talk about it off the background of the fact that there's some fundamental changes in terms of South African telehealth, telemedicine practice. I'm going to talk about those off the back of the HPCSA ethical guidelines, and off the front of the fact that as recently as this week, the HPCSA has published new telehealth guidelines. So if you haven't got it, I suggest that either you source it or you're welcome to get a hold of me, and I'll share that with you. But we live in interesting, changing times. Groups like Google's DeepMind or IBM's Watson's Health, Babylon Health are providing cognitive technology that is letting chatbots assist with diagnosis, providing medication reminders, doing appointment scheduling, doing triage in the emergency rooms. You've got groups that are using machine learning to give responses to verbal questions and probes. We're starting to do tele-assisted, technology-assisted surgeries. We're using different smart and medical devices and home-based monitoring devices to detect heart problems, arrhythmias, diabetic insulin changes, and create pharmacogenomic-based therapies to customize treatment options and medication regimes. So fundamentally, the use of artificial intelligence, the use of machine learning, the use of how we consolidate data is all part of this journey into electronic health. And part of the journey into electronic health is the concept of telehealth. So when we talk about telehealth and we talk about wearable devices, and many of you will be able to look down and you'll see that you've either got a smart device on your wrist, and or you've got smart devices in your practice, and or you've got patients who are monitoring certain metabolic or cardiac or key vital sign functions. The basis that sits behind that is a set of guidelines that are called the Continua Design Guidelines. And these are guidelines that measure and interlink medical devices across the world. They work off a platform called Fast Healthcare Interoperability Resources, which is FHIR, and they align through an alliance called the Personal Connected Health Alliance, the PCHA. Now, the whole purpose behind that is that the enterprise of integrating healthcare and the API, or the application program interface, is met with the supportive legislation that protects the device management companies, the practitioner, and the patient. So in the US, you've got the 21st Century Cures Act. You've got the Global Digital Healthcare Partnership, which came through in 2018. The Health Insurance Personal Information Act in 1996 in the US, with the GDPR, which is in the EU, with PIPEDA, which is in Canada, with the POPI Act, which is here, are all designed and came into force to make sure that a person's personal information, a patient's information, your information when you're a patient, is dealt with and managed with degrees of discretion. And so when we start talking about electronic health and telehealth, this becomes more and more important. So to give you a sense of what the landscape looks like, from the device that you use via Bluetooth or via USB or via Wi-Fi, through personal health gateways, through both the health and the health and fitness industry, that information ends up in some kind of healthcare information system. It might be a hospital information system like a HIMSS. It might be your clinic information system. It might be an aggregated system. But every time we talk about telehealth, we need to start considering in our own world, how are we connecting with that individual, that patient, and with our colleagues? How are we collecting information? How are we putting that information into a storage system that's consistent with what our ethical guidelines require of us in terms of informed consent, in terms of managing privacy and confidentiality and disclosure, in terms of our record keeping, and in terms of managing patient rights? So for a lot of the discussion that we're going to do for the next 40 minutes, we're going to talk about those things, but I'd like you to bear in mind that all of that falls into this FHIR structure. Even if you're doing a telehealth consultation using WhatsApp or using FaceTime or using Zoom or using Teams or using BlueJeans or whichever technology you're using, the collection of that information, if there's interoperable devices or if you're sharing it using electronic record systems, this is the kind of framework that underlies the relative simplicity of having a telehealth consultation. I do want to pause at this point and say, we're going to go through a fair amount of information. Please stop me at any time. And in the chat box, if you've got a question, put that question through. I'll answer it in real time as best I can. I'll answer it also with the caveat of saying the world of digital health, not only in terms of this slide with how the World Health Organization categorizes telemedicine, but also how we execute that and how we execute that now within the country and on the continent is changing at the speed of thought. So the changes that we're seeing now are based off revisions to the ethical guidelines, which are based off clinical recommendation guidelines, which are based off best practices, which are less than 5 years old. So let's recognize that when we talk about digital health, we're talking about consultations between remote clients and healthcare providers. We're talking about remote monitoring of client health or diagnostic data by a healthcare professional or a team of professionals. We're talking about the transmission of medical data to a healthcare provider, either by a patient or by a colleague or by a network of colleagues. And then we're talking about consultations for case management between healthcare providers. So all four of those categories fall into the definition of telemedicine services. When we look at telemedicine across Africa, because we are at the tip of Africa and the southernmost tip, and for those of you that want these references, I'm more than happy to share both the references and the research. We can see that in terms of our world, out of the 31 African countries, the majority have fewer than 10 doctors per 100,000 people. Where if you compare that into the EU, where Germany, there's 240 doctors to 100,000, Italy has 370 per 100, and Norway has 380 per 100. So we have a significant scarcity or shortage of healthcare professionals in Africa. So I do know that recently the message that came through was that healthcare professionals was off the scarce resource list within the country, our country, but on the continent, our ability to service our urban and peri-urban and rural populations is significantly impaired by resource availability. So there are some interesting articles that you can read on this. One is the M for mobile, so the mobile health policy readiness and enabling factors, comparing the sub-Sahara and OECD countries to each other. That was published in 2018. And the use of telemedicine in sub-Sahara Africa, which was published in 2021 in July. So there's fairly contemporary research which would give you a context of how we're managing both mobile health and telehealth. Why do we need this? Why are we embracing this and driving the strategy so strongly? One is mobile health and electronic health and telehealth is definitely a powerful tool for communicating behavioral change. And here we're talking about health and societal health behavioral change. It also helps in terms of clinic appointments and medication reminders. We know through the WHO medication safety strategies, and also you'll know from your practices, clinic appointments, people forget them, people aren't always compliant with their medications, especially their chronic meds, and sometimes that leads to complications in terms of drug resistancy or in terms of significant secondary and tertiary comorbidities because of non-compliance. It's also useful for monitoring and managing diseases, and in this case, monitoring and managing the pandemic results. Also in terms of data collection and tracking, it's important. We find that in areas where we're using mHealth and telehealth, we've got improved communication amongst healthcare professionals and between patients and providers. I know I was risk manager in a hospital where we would do the trace of the echo and the ECG in one region. We would transmit those results to another region, and we would create a dual center of excellence to allow that to happen, where the patients could then, without being able to have a deep skilled resource on site, still have the benefits of cardiac review. Also, telehealth and mobile health is really important for both the education of us as healthcare professionals and as patients. And certainly where we use it well, the ability to educate our patients into the importance or the understanding of their disease and the importance of care becomes fundamental. So the challenges in bringing this into place is, do we have policy readiness? And we can see already in terms of the changes that I'm going to take you through with how we define telemedicine and have expanded that to telehealth. We're seeing that in terms of our telemedicine and telehealth policy within the country, within our e-health strategies within the country, and within our ethical guidelines, that we're seeing quite a lot of revision around telehealth and social media risk. There are barriers as we're experiencing during load shedding and otherwise, both to bandwidth and internet connectivity. Software upgrades and devices are expensive, and there's a maintenance cost issue. We don't always have locally trained and certified technicians to help us. Not all of our staff are skilled. Not all of us are skilled. And sometimes there's a user acceptance issue where people struggle with doing new things. And telehealth is certainly one of those very new things that we need to be mindful of. So when we look pre-COVID at the trends that were predicted in 2020 and 2021, there was a significant shift both from the consumer and the provider, where pre-COVID, only roughly 11% of patients considered using telehealth, whereas by the end of 2019 and 2020, you had up to 76% of people willing to use it because of the issues as it related to access to practitioners as a result of COVID. When we start looking at healthcare systems and practitioners, the number of people using telehealth has increased significantly. And hello to everyone. It has increased by 50 to 175 times, and that was pre-COVID to COVID. And significantly more people are more comfortable using telehealth than they ever were before. Now, having done telehealth consultations, there's benefits to them, but there's also, I found, significant challenges. And it's not always as effective or as efficacious as we might want it to be. So when we looked at trends, and this was a study published by McKinsey and Company in November last year, we looked at growth in telehealth usage that peaked in April 2020. But it peaked, and where it stabilized now, you can see it stabilized at a significantly higher level than it was in 2019. So globally, what the pandemic has done is it's created a 38 times increase in the number of telehealth consultations. And that is in a variety of disciplines, and I'm going to show them to you here. Now, not all disciplines are created equal when it comes to being able to use telehealth. And so the forecasted trends show that ophthalmology, orthopedic surgery, and general surgery and neurosurgery are the least likely to be adopting and using telehealth on a broad basis, whereas psychiatry, treatment for substance abuse disorders, endocrinology, and rheumatology are more likely to be able to use them as disciplines. And partly that's because there are certain disciplines that you have that are hands-on, where you need the person in front of you in order to do a thorough diagnosis or do an intervention or do a procedure or treatment, whereas others, you've got the ability to intercede in a slightly different way. So the sense moving forward, CAGR there stands for compounded annual growth rate. And so there is a sense that there will be an increase in direct to consumer and direct to patient growth. There was a reduction between 2020 and 2021 in terms of ambulatory care. And part of the reason is people want to reintegrate. They want to remove the social barriers, and by and large, they want to see their practitioner. So there has been a year-on-year decline between 2020 and now in terms of telehealth for ambulatory care. We're seeing a slight increase in terms of emergent care for surgical support and for tele-ICU, because in certain cases, there's just not the access that would be ideal. And in terms of transitions of care for chronic and post-acute care, we're seeing some increases. So the truth is, at the moment, we don't really know what the post-COVID, post-pandemic world will look like, but we're certainly seeing, and you'll probably see this in your practice, a significant uptick of face-to-face consultations as people want to reintegrate. There is a strong social drive for social connectedness and a culture of intimacy, which we, through lockdown, have lost. And that's created within itself PTSD and mental health challenges, which are slow to emerge. So some of the things that we're seeing in terms of telemedicine trends, we're seeing electronic health record embedded telehealth care with seamless interoperability and up-to-date data always in place. There's also the opportunity now using electronic health records for data deduplication. We're also seeing that there is a significant use of wearables, medical wearables, the cross-platform applications and the real-time data exchanges between your wearable and your handset, your wearable and your electronic record, or wearables and other monitoring devices. We're seeing a significant change there. We're also seeing a significant change in the use of data analytics and machine algorithm to support decision-making in healthcare. Now, that brings about challenges about what data that you can use and what data you're allowed to use. And we're going to talk about that a little bit in terms of POPI and in terms of the Consumer Protection Act and the constitutional protection of health data. But also, there's the increasing use of augmented reality for quality care. And some of that is around using advanced medical imaging. And I know if you're using PACS systems and you link to your local imaging partners, you're able to see images in ways that we were never able to do before. You can enhance them, you can highlight them, you can rotate them, you can view the CT, MRI, Doppler, ultrasonography in ways that was never there before, because that then allows for augmented reality navigation, certainly in arthroscopic and laparoscopic training, surgical training. We're also seeing it in the training systems that there's a big change. Sometimes, and it's early adoption, we're also seeing this come through in terms of robotic surgeries and improvement in access to remote care. So how ready are we for this? When we look at OECD versus Sub-Sahara, you can see that there's countries that are very ready. There's high levels of adoption. Then you can swing down into the middle and you can see where we sit close to Hungary, Niger, South Africa, Belgium. We are remarkably well equipped in terms of policy readiness and policy readiness score for being able to implement and provide mobile health and telehealth within the context of this country. You can see that on the left-hand side, you've got Sweden and Canada, Latvia, Turkey, United Kingdom, Netherlands are very well equipped. But given our bandwidth and access, we are very well equipped, but within a very small number of consumers, both in terms of us as providers and in terms of people who are able to use that. So if we pause now and we reflect, we asked the question, well, what are our guidelines and regulations that enable telehealth and telemedicine to occur? So our Constitution makes provision for this in terms of equitable access to acceptable and adequate healthcare for all, which is Section 27 of our Bill of Rights. Our National Health Act enables this. Our HPCSA ethical guidelines do. And if you don't know these guidelines, I do strongly suggest that you download them off the HPCSA site. Booklet 1 around our ethical conduct and 2 around our collegial conduct is important. Booklet 3 speaks specifically around patient rights and the National Patient Rights Charter and the duty and obligations of us to our patients, but also of our patients to themselves and our patients to us in terms of disclosure, compliance with care, looking after their own health. So those of you that aren't familiar with the National Patient Rights Charter, it's probably a good idea for you to go back and revise it. And then obviously and importantly, the booklets on informed consent, on confidentiality and disclosure, on record keeping, because one of the biggest challenges now as we get into this more technology-driven age is how are you keeping your electronic records? If you're not using them by hand and you're using pen and paper, then the question would be, well, how are you using them? Are you dictating with voice to script? Are you typing them out? And if you're doing telehealth, how are you recording those consultations after the fact? And then booklet 10, which was revised at the end of 2021 in December and just released now, is the booklet specifically on telehealth and telemedicine. But I also refer you to the booklet on social media risk, because this revision on telehealth makes specific reference to the engagement of using social platforms. And I'll talk about this in the next 30 minutes. We also have an e-health strategy. We also have guidelines that were published on telemedicine as of March 2020, and guidance on the application of these regulations, which came out in response to the country's needs to provide more than telemedicine as it was defined in the previous regulations, and that was in April 2020. We have an act called the POPI Act, which many of you, or you should all be aware of now, which speaks specifically to what they regard personal data to be, which is all health, biometric, and medical related data of a patient and how it needs to be managed, and our obligations as information officers to protect that information, to use within consent, that the information that we're collecting is only going to be used for the purposes that we collect it, and how we store it and how we process it is important. And then recently, the practice guidelines for South African telemedicine were released. So there's a lot of movement in terms of the guidelines and regulations for telemedicine. And the definition that's currently in term is the use of medical information exchanged from one site to another via electronic communications to improve a patient's health status is regarded to be telemedicine. Now into that, telehealth encompasses telemedicine, but it also includes remote healthcare that doesn't always include clinical services, such as the monitoring of wearable devices. So there's been a change and we need to recognize that telemedicine is not a separate medical specialty. All the products and services that relate to telemedicine are often part of a larger investment by healthcare organizations. And that's either in ICT and information communication technology or through the delivery of healthcare. So telemedicine is broad, and it encompasses many different types of programs and services that are provided to the patient, which could include e-scripting. It could include the mechanisms of you using your PAC system to review imaging and results, or your laboratory systems. Or an example would be, I needed to do PCR testing for the national team that I represent, and the results that were then sent to me as PDFs on an individual basis would technically fall into the telemedicine and telehealth definition. So many different consumers can be involved, many different providers can be involved. Now, the first amendment that significantly shaped our world was when telehealth was allowed, where our telemedicine definition was extended to telehealth. And that was first on the 26th of March in 2020, and then formally on the 17th of April, where telehealth was separated from telemedicine. Was telemedicine required you as the practitioner to be in the room with a patient or to support another healthcare practitioner who was duly registered, who was in the room with the patient. And subsequent to the lockdowns, which we now know would have been coming into effect this weekend 2 years ago, it said that telehealth should be practiced preferably in circumstances where there was already an existing practitioner-patient relationship. And where there wasn't one, we could do telehealth provided that they were in the best clinical interests of the patient. Now that hasn't changed. There's still the desire that you don't enter into a telehealth relationship, except in emergencies, with patients who you don't have a pre-existing relationship with. But since then, things have expanded. And now with making reference to the booklet as it's just been published, the HPCSA referred to the guidelines historically as telemedicine guidelines, but now there's this more inclusive term that accommodates all relevant professions, and that's what the HPCSA is referring to as telehealth. Telehealth is also part of the strategy to reach universal health coverage by improving access to patients and the access for these patients to both quality and cost-effective health services, regardless of where they are. So in terms of focusing on remote patients in remote areas, in terms of focusing on patients who are considered to be vulnerable groups, and those would include those with morbidities and comorbidities where exposure to public transport or removal out of an area that's a safe environment for them could potentially put them at risk. And those in aging populations would fall into those primary future users of telehealth services as intended in terms of these definitions. So when we look at the telehealth system specifically, we're looking at it in terms of the desire to deliver healthcare services at a distance. So these highlights, the bold italic and underlined highlights are my highlights to try and illustrate what the sense is that is trying to be achieved by the increasing use of the telehealth system. So delivering healthcare services at a distance is the intention or the objective behind telehealth services, especially in the underserviced areas. So as we move forward in the increasing use of this, we're also looking at this to alleviate us as the human resource crisis and spread experience, healthcare and healthcare professional experience between developed and undeveloped healthcare facilities, and especially those where there may be different categories of healthcare providers. So this is purpose is to replicate and augment physical consultations, but not to be a substitute. So one of the statements that's made in the new telehealth booklets is that no practitioner may exclusively render professional services through telehealth. We've had a lot of questions to say, well, can I transform my practice exclusively into a telehealth practice? And the new booklet and specifically section 3.8 says no. You may practice a portion of your practice in a telehealth environment, but the majority of your practice needs to still be a face-to-face practice providing physical consultation. Now that may change in the future, and it may change depending on specialty or subspecialty or scarcity, but for now, you shouldn't be gearing up your practice to be an exclusively remote telehealth practice. Now, one of the things that comes up is the question of social media. When is telehealth a social media exercise, and when is telehealth a diagnostic and consultative exercise? So using social media platforms for the purpose of telehealth is not desirable. You're encouraged not to interact with your patients via social media platforms. Now, when we start talking about social media platforms, and we do a separate conversation about this, but it pays just maybe to define what we mean. A transactional platform may be considered to be your Zoom platform or your Teams platform, or possibly at extension, your FaceTime platform or your WhatsApp for Business platform. A social media platform might be considered to be Twitter, Facebook, LinkedIn, where you're not in control of the information that's being shared. Sometimes, and we've seen this a lot, you might give an opinion, and that opinion or that attitudinal position or that diagnostic opinion or that advice that you give is shared much broader in a manner that you hadn't intended. So you need to be mindful of how you use telehealth and how to recognize the difference between you creating a telehealth one-on-one or one-on you and a patient and a practitioner environment versus the use of a broad-based social media platform to provide healthcare related consultation and advice. You also need to bear in mind that with the POPI Act, as it's come through now, the POPI Act prohibits you getting information about a person outside of their healthcare setting. So now, if you've got access to a patient's social media profile, for example, a patient comes to see you for a particular injury or a particular healthcare condition, but you know them socially or you know them on social media and you follow each other, you may see them engaging in activities or promoting activities that they haven't disclosed to you in the therapeutic environment. The challenge that you have now is you know information about them that they haven't given you in the therapeutic environment, which you now can't bring into the therapeutic environment without their endorsement. And that creates often some ethical dilemmas, which are very difficult to work your way out of afterwards. So be aware that the challenge of providing telehealth in our socially connected world, which is so grossly socially interconnected at the moment, does create challenges for you. So within telehealth, now within the South African system, the HPCSA in their booklet in sections 4.1 to 4.3 have defined telehealth slightly further. And they're defining telehealth as being routine telehealth, being the routinely or commonly patient-initiated discussions that you have with them, or where you are using a second practitioner to get a second opinion. That's considered routine telehealth. There's also the belief now in specialist telehealth, where it's anticipated that's where the bulk of telehealth practices will happen, because we don't have enough specialties and subspecialties, especially in rural areas. So the practitioner will reach out to you and say, can you do a interpretation of these results, or can you have a look at this tracer, or can you give me an opinion on A, B, or C? And then the third type, which will be emergency telehealth. And the challenge, and I've taken out an extract, because emergency telehealth can be quite difficult, especially when you're trying to triage a patient you can't see. You cannot see what they look like, you cannot smell them, you cannot feel them, you cannot see what their levels of discomfort are. And so the outcome of that should be that all your emergency instructions should be in writing and appropriate to the services being rendered via your telehealth platform. So there are tremendous challenges in bringing this to bear. And part of that is your awareness of what you're needing to do. So when we speak about telehealth now and telemedicine, and we start talking about what might be considered to be part of telehealth and telemedicine, one of the things will be all your video conferencing. So this is a video conference that we're on now. This is telemedicine and telehealth. Anytime there's a transmission of still images, that's regarded as telemedicine and telehealth. And I'll sometimes get a picture where somebody sent me a screenshot of an x-ray or a screenshot of a part of their body, and they'll say, well, what do you think? Well, the minute you receive that and they can see that you've received it, so let's say it's on WhatsApp Business and you get 2 blue ticks. Well, now you've entered into the therapeutic agreement with them. The difficulty is you might not have all of the context. You might not have the clarity of the image. You might not be able to see the body part in the right positioning. But all transmission of still images is regarded to form part of this. All patient portals that you're using, if you're using electronic health records, or if you're asking your patient to submit their data, or you're asking them through, and I mentioned this earlier, through an application program interface and API to send you things, that's telehealth. Any monitoring you're doing of vital signs or of diabetic monitoring devices, is telehealth. Any continuing medical education like we're doing, not only between colleagues in healthcare, but also in terms of sharing information between ourselves and our patients, is telehealth. And all nursing call centers where somebody's calling in for mental health issues or environmental issues or poison lines or health lines or abuse lines are also considered to be telehealth and telemedicine. So you can see here that the scope of telehealth and telemedicine is considerably broad when we start looking at it within the context of this environment. So what does that mean for us? Well, it means a couple of things. You as the healthcare provider need to ensure that the service that you're doing via video conferencing or via teleconferencing or the interpretation of what you're receiving is in line with your scope of practice as registered in the relevant regulation. Now, why do I say this? Is because sometimes professionals say, well, it's not in my scope, but I can do it. And there's a difference between what you can do, what you think you can do, and what your scope of practice can do when we look at this, what we call the cold black letter of the law. So I've been doing medical legal work in various forms now since the mid-2000s, probably in 24 countries around the world as part of health risk programs where I provided insight and oversight. And the same problems come up over and over again. And one of them is what the practitioner believes that they can do, what their scope of practice says they can do might be different. So you need to make sure that in terms of the Health Professions Act, in terms of the HPCSA guidelines, and in terms of your written scope of practice in your specialty or subspecialty or general practice, matches what you're doing on a telehealth and in physical practice basis. You also need to make sure that even if it is within your scope of practice, that you have the appropriate level of qualification and that you are both capable and competent and experienced to do what you're delivering. So you may be highly skilled and highly educated, but have very little experience in doing telehealth in a manner that's safe. So you need to make sure that you're adequately skilled and working in lines, both with your scope of practice and your competence. It's also important to know that as a practitioner, as a registered healthcare practitioner, you can support any other practitioner who's duly registered under the appropriate acts in terms of telehealth and telemedicine. Recalling, of course, that telemedicine by South African definitions was the support of a healthcare professional with a patient by another healthcare professional who was remote from them using digital technology enabled applications. So finally, what you need to bear in mind that what you deliver to your subset of patients in terms of, for example, mental health or poison support or general diagnosis must match the level of skill and application that your service delivery or your healthcare delivery team has. So it's not enough that you have the skills, but if you're working with an environment that's multidisciplinary, you need to make sure that those other persons have the skills too. So these are the things that you need to consider as we go forward and as we come almost to the end of this discussion so that we can start reflecting and asking questions. You need to be mindful that within telemedicine, you must be aware of the professional disciplines and guidelines and standards that must be upheld in all telemedicine and telehealth encounters. And you need to be sure that you're considering the specific context, the specific location, the timing, and the services that you deliver to the patient. Now, what does that mean in real terms if we break it down? It means that in terms of your ethical guidelines, that you're not doing supersession and removing or shifting a patient's healthcare away from a colleague to yourself. You also need to bear in mind that you need to be respecting that patient's rights for the access to care. The patients, and this is in booklet 3 under the National Patients' Rights Charter, you need to be aware that you're also respecting their ability to have a known healthcare consultation with a known named practitioner in a manner that's consistent with their requirements. Then you need to make sure when you go through this with your patient or with your colleagues and your patient as to how you do your informed consent. And we're going to talk about that in the next slide or two. How are you getting meaningful consent? That the patient understands the platform that you're using, they understand what you're going to do with the records that you create, how you're going to create and store those records, how you may or may not share those records with another person. In other words, confidentiality and disclosure. You also need to make sure in terms of booklet 9 that you're taking contemporaneous notes. And we're going to talk about that in a little while. You also then need to consider how are you going to record the context, location, timing, and services that you're delivering to that patient. If you're scripting and you're e-scripting that patient, how are you going to give them that script? How are they going to receive it? How's the pharmacy going to respond to that? You also need to make sure that both you and your patient are culturally competent to both deliver and receive services in the populations. So you need to be aware of language. And for language, one of the things to give you a point of reference is that the person who you are looking to get consent from in terms of the National Health Act needs to get information in a literacy independent way, in a manner that they can understand, which means you've got to take not only language, but ethnicity, race, age, gender, sexual orientation, geographical location, and their socioeconomical and cultural backgrounds into consideration, and reduce that into a permanent record that persists. And that takes you through booklets 9 and into booklet 10. So some guidelines for consideration is that your personal discretion in terms of engaging with telehealth, in terms of the diagnosis and the scope of care or treatment, should not be limited or influenced by the non-clinical considerations of technology. So what does that mean? It means that when you're starting to work with your colleagues, some of the questions that you need to ask yourself is, can you reach a diagnosis? Can you reach your diagnostic opinion only doing a telehealth consultation? Are you able to get the temperature you need? Are you able to get the vital signs that you need? Are you able to adequately see the patient with lighting? Are you able to engage with them in a manner that gives you the right information in your clinical setting, considering that they may have a phone where the camera doesn't work very well, or they may not have the kind of lighting or privacy that's needed for you to ask them the kind of intimate questions that they would need to answer for you. Then finally, let's break this down. There's the need to review or to assess the severity of symptoms, both physical and psychological symptoms. And you need to consider that when you go into a telehealth consultation. You also need to consider whether you have previous knowledge of that patient and client, as well as that of the family and of the wider situation, and that's as appropriate. And can you access their clinical records? So sometimes you'll be doing a consultation, but you may not have the records on site. And one of the benefits currently of using digital or on-site records is most of those records can be accessed in remote areas. A consideration for you in terms of how you conduct your telehealth consultation is, will you need to physically examine that patient? And you'll notice here that the HPCSA in their booklet now starts to talk about a patient or a client. And why that's important to you is because we also have to bear in mind that there's the Consumer Protection Act. So not only now do we have to think about our National Health Act and our Health Professions Act and our scope of registration, but we also have to think about POPI and how we manage personal information. We have to consider FHIR, the Promotion of Access to Information Act, where a patient can ask you for their information, which you're then obligated to provide them. But there's also an act called the Consumer Protection Act. And so when we talk about the National Health Act, we talk about ourselves as being practitioners and the other party as being the patient. But there's also us providing a service. And when we provide a service and the patient receives that service or becomes the consumer or the client of that service, then the Consumer Protection Act also plays a role. So you need to be aware that when you talk about the Consumer Protection Act and you recommend the use of an orthotic or a prosthetic or a medical monitoring device, or any kind of medical aligned or non-medical device, you're now governed by the responsibilities that that act creates as well. You also need to bear in mind when you look at these guidelines to consider whether the previous medical history may require the need for you or somebody else to see that patient face to face. And you need to make notes of that, and you need to make provision that when you see the patient, that you have the clinical notes that are appropriate, that your assessment as a telehealth assessment is appropriate in terms of their physical or physiological or psychological symptoms, that you have access to their records, that you also explain to them that you may need to see them physically, and that you may need to do that, or they may need to go somewhere where the telehealth consultation becomes a telemedicine consultation. And then finally, and this is in terms of section 5.7 of the ethical guidelines, it's good practice for you to consider the social circumstances of that patient and whether the clinical or social background requires you to physically see that patient. But when you're the servicing practitioner, when it relates to ethical guidelines for telehealth, you need to make sure that you're recording the location of yourself as the consulting practitioner, that you're recording the identity and qualification of the consulting healthcare practitioner if it's not you, that you're also recording the identity of that patient. And if that patient is not with you, that your records also consider and record the location of the patient. Because when you and the patient are in the same place, it's fairly straightforward to manage that. But when you and the patient are in different places, suddenly your location becomes important, as does the location of the patient. So things that you need to bear in mind is how you provide informed consent and respect the rights of your patient. Do you have written down consultation protocols for remote and digital healthcare, both telemedicine and telehealth consultations? How are you recording records? Are you recording the telehealth consultation? Are you recording the video and the voice? Are you informing your patient that you're going to be recording that? Are you getting informed consent from them in writing or in some kind of explicit manner? Do you have permission to disclose this information to other healthcare professionals or to other parties? If you're using e-prescribing, are you going to use scripts with encrypted signatures? Are you aware of what your requirements are in terms of handwritten and typed scripts for which schedules of medicine? How are you managing transitions of care? If you're doing the telehealth consultation and that person needs a face-to-face consultation, how are you going to do the handover of that patient from you to me if your consult was recorded digitally? Do you have permission to share that information? Are you going to be able to do that in a thorough, protected way? And then, as we spoke about a little earlier, bearing in mind data protection. And there you can see a whole lot of acronyms. That's the National Health Act. It's POPI, the Protection of Personal Information Act, which also requires you to get permission for the collection, the storage, the transmission, and the processing of that information. Even if you're going to use that information for case management, or if you're going to use it for CPD with your colleagues, you need information and permission from your patient in writing for that. FHIR we've spoken about, and that's the Promotion for Access to Information Act, which means any patient at any time can have a written request through that act and through the structures for their patient records, where you may not unreasonably withhold. The Consumer Protection Act we've spoken about, and I've spoken about at least booklets 1, 3, 4, 5, 9, 10, and 16 that you need to know in terms of the ethical guidelines for providing telehealth. And with that, I want to say thank you very much. Jeanette, I'm going to hand back to you now so that we can manage and answer any questions. I'm going to keep my video off because of load shedding, I'm in the dark. So even if you wanted to, you couldn't see me, which is probably a good thing.
Brad, can you hear me?
Yes, absolutely.
Oh, thank you very, very much. Thank you for your insightful and thought-provoking presentation on telemedicine and telehealth. It's an excellent presentation and very insightful. I think there's a lot of questions that can be posed, as the telemedicine and telehealth is a vast and onerous topic, as per your presentation and the detail that you've shared with everyone. I'm sure that from your presentation, there are going to be many questions that are posed on the group. Please post your chats. Brad will answer you immediately with any questions. You can see there are so many considerations that need to be taken into account on the guidelines of considering and the delivery of healthcare. I mean, I can't even start from the presentation. Brad just jams in so many aspects that you probably could watch the presentation 3 or 4 times and still learn new aspects of telehealth and telemedicine. So thank you very much for your presentation, Brad. It was an exceptional presentation. And over to the floor. If there are any questions, please can you raise a hand or ask the question or put it in the chat facility that Brad can respond with the questions. Thank you very much. No questions yet.
I think maybe people are just overwhelmed by the relative simplicity of telehealth, but surprisingly how technical it is behind the scenes.
I agree.
Either that or load shedding is making it less interesting for people to chat. For those of you that are interested, and if you don't want to ask some questions here, I'm very happy to share through the society the latest guidelines which were circulated. I received the new guidelines as recently as Tuesday. I can tell you, while you consider if there's any questions, that there are several forums that are multidisciplinary input forums that are looking at telehealth, that are also looking at the interoperable use of various electronic platforms to provide care and support. Tanya, I see your hand is up. If you want to unmute and ask a question, you're welcome.
Thank you, Brad, and thank you for your excellent presentation. I think this is very insightful also for our members from ASAIPA side. Thanks a lot, and please do share. We can then also circulate to all the members attended as well as members that would be interested.
Absolutely.
Well, Brad, if there's no questions further, I'd like to say thank you. I know it's been a jam-packed presentation, so thank you for your contribution to this evening. We look forward to a future event with ASAIPA with you. And Tanya, thank you for facilitating and the CPD event. Thank you for all the doctors that took the time out this evening to attend. We look forward to engaging with you on many aspects in the forthcoming year, and thank you for the opportunity of being a strategic partner with ASAIPA. I hope you have a fantastic evening further. Thank you very much.